So now we're going to talk about anticonvulsants. If we talk about anticonvulsants, we need to talk about epilepsy. Epilepsy is a neurological disorder marked by sudden recurrent episodes of sensory disturbance, loss of consciousness, or convulsions associated with abnormal electrical activity in the brain, lightning storms in the brain. We really don't know what the cause of most of these are. Sometimes seizures can be secondary to trauma, anoxia, infection, or stroke. Sometimes isolated seizures can happen due to fever, electrolyte imbalances, or acid-base imbalances. Strong characteristics of some types of seizures can include loss of consciousness, convulsive movements, and again, it's those abnormal electric discharges from cerebral neurons, and you can think of them as just little lightning storms. Seizure classification is something that's not fully agreed upon by all neurologists. We tend to split them up this way for this class because that's what this book is doing. We split them up generalized versus partial, and then in the generalized seizures we look at tonic, clonic, and absence seizures. In the partial seizures we look at psychomotor seizures. Those ones are more localized. So anticonvulsants and anti-epileptic drugs. So don't get anti-epileptic drugs confused with anti-lipemic that we will talk about later. They kind of sound alike, so I want you to really watch that spelling. Anti-epileptic are also anticonvulsants. Some suppress sodium influx to a cell, some suppress calcium influx to a cell, and some either enhance or promote GABA release, which results in a quieting or a calming of the neuron. Hydantoins. An example of a hydantoin. This is a type of anti-seizure drug, and an example of one is called phenytoin. It's definitely not okay during pregnancy. Very, very teratogenic. It also decreases the ability of your birth control pills to work. So it's really not recommended in any of the childbearing ages. It also decreases the folic acid in your body. So this is really a bad thing in pregnancy. Therapeutic serum levels are quite narrow, 10 to 20 micrograms per mil. We watch those. We also watch for side effects and adverse reactions like gingival hyperplasia. Make sure kids are brushing their teeth if they're on this, and grown-ups, but kids are people that we need to really watch with that. Nystagmus, slurred speech, decreased coordination, alopecia, thrombocytopenia, Stevens-Johnson syndrome. And sometimes there are more, but these are some of the common and dangerous side effects. So some of these things on here are just to help you remember those side effects of Dilantin and many of the other hydantoins. Then we move on to barbiturates, which a famous barbiturate is phenobarbital. So now, phenobarbital usually comes in an elixir. An elixir is a liquid medication, and so when you get those, you want to shake them well. Any seizure med that comes in a liquid needs to be shaken very well, as the medication itself likes to settle to the bottom of the bottle, and so you end up with high concentrations of it in the lower part of the bottle, low concentrations of it in the upper part. And so shake well. And in fact, unless we tell you to not shake something, you really should mix it well. It treats partial seizures, grand mal seizures, acute episodes of status epilepticus, although it's not gold standard for a status epilepticus, meningitis, toxic reactions, and eclampsia. Therapeutic serum range of phenobarbital is usually 20 to 40 micrograms per mil. There are risks. There's sedation risks in a patient who becomes tolerant to the drug. Intolerance develops because your body becomes homeostatic to that drug and requires more and more of the drug. So people should be warned against discontinuous without doctor supervision. Discontinuance of phenobarbital, as any seizure medication should be done through the physician. It should be gradual to avoid the recurrence of seizures. Benzodiazepines. So benzodiazepines, we need to be really clear that these are the meds we want to use if someone goes into status epilepticus. So if someone is prone to status epilepticus, sometimes they will have a pen filled with a benzo or a syringe filled with a benzo, and maybe their parents carry it around. But we have benzos in healthcare, and when someone goes into status epilepticus, we can give it to them IV. We can give 5 milligrams of diazepam and or what I really mean is we could give Ativan 4 milligrams IV. So clonazepam is effective in controlling some petit mal absence seizures. Tolerance may occur 6 months after drug therapy starts. Clorazepate dipotassium is administered in adjunctive therapy for treating those partial seizures. And diazepam and lorazepam, like we talked about for acute status epilepticus, must be administered IV to achieve the desired response. So just keep in mind, if you reverse a benzodiazepine, remember how we've got all those reversal agents? We're keeping a small log on all the reversal agents. What was that reversal agent again? The benzodiazepine reversal agent was flumazenil. So when we give that reversal agent, we need to be watching for seizures. So short-term effect, though. So we need to remember that these are really a short-term solution to seizures. They're not necessarily a long-term solution, although they are gold standard for status epilepticus. Iminostilbene, like imipramine and carbamazepine, are things that you will see when other medications aren't working. So it says effective in treating refractory seizure disorders that have not responded to other anticonvulsive therapies. So refractory just means we've treated it and it's not responded like we wanted it to. So it's used to control grand mal and partial seizures and in combination of these seizures. I often see it also used in the ICU quite a bit. It can be used in alcohol withdrawal. Imipramine sometimes is used in trigeminal neuralgia as an analgesic. People get headaches from that. And also for some psychiatric disorders. Valproate, definitely not for kids under 2 years old. Extreme hepatotoxicity. So really be watching those LFTs. If the LFTs are high, doc, you're going to have to let the doc know. They might want to change this medication. Therapeutic range is 50 to 150. Again, greater than 150, they're going to be sedate. You don't want to just stop a seizure med without consulting the physician. It's just not okay. So you've got to make sure, even if you're higher than that therapeutic range, that you've spoken with the physician before you move that range around. Anticonvulsants in pregnancy. Again, I want to reiterate, anticonvulsants are not always the best in pregnancy. So if we go back to things like Dilantin, remember that Dilantin was absolutely horrible during pregnancy and in fact increased your risk of becoming pregnant if you're on birth control. We also look at things like excuse me, phenytoin. Phenytoin is metabolized faster in pregnant women, so you see episodes of seizure increases by 25% for pregnant women. And if they do have seizures, if they have hypoxia, it's a huge problem, not just for them, but for the fetus too. Many anticonvulsants are teratogens. Teratogens are medications that cause problems to the fetus. Many anticonvulsants inhibit vitamin K, so baby is at risk for hemorrhage. This is a greater risk outside of our own country than within the United States, as babies are receiving vitamin K. Anticonvulsants increase the loss of folic acid in pregnancy. So anticonvulsants and febrile seizures usually happen between 3 months and 5 years of age. Epilepsy only develops in 2.5% of those who have had febrile seizures. Phenobarbital and diazepam are used for these. And then, of course, we want to bring that fever down if it's causing seizures. This is why we treat fevers in children, because we don't want to change their seizure threshold. So valproic acid, once again, repeating, should not be given to children under 2 years of age, as the hepatotoxicity is a gigantic problem. Status epilepticus we talked about earlier. When people undergo this, they are undergoing one of the biggest lightning storms that their brain will ever experience. So the treatment we talked about earlier was Valium, Ativan, Dilantin, or Versed. And then we can also use as an adjuvant propofol or Diprivan. The idea with this is also people are moving those muscles around quite a bit. There's excessive use of those muscles, sometimes some protein breakdown, and looking at this pharmacologically, we need to make sure that those people are well hydrated after this starts. We don't give them oral things. We can give them IV meds to hydrate them, but to flush those protein byproducts out of their kidneys so they don't end up with some permanent renal damage. Succinimides are at the end of this, but we will talk about succinimides in a different lecture. So that wraps up what we're going to talk about in